Thank you everyone for attending. My name is Joseph Tartaglia. I'm an attending at Greenwich Hospital. I have 3 boards in internal medicine, geriatric medicine and cardiovascular disease, and nuclear cardiology. I'm assistant professor of medicine at Weill Cornell Medical College. And today I'm going to talk to you about the current state of cardiovascular disease. I want to touch on certain topics that I think might be of interest to you, and what I find fascinating about how cardiology is changing and how it can also influence our lives in a much more positive way than before. But before I go into discussion of some topics I had planned, I do want to talk about COVID-19, and how it affects the heart, because this has been in the news lately. And first of all, I want to say to everyone here that the disease is far worse than the vaccine, 1,000 times worse. So I don't think anyone here should be afraid of getting the vaccine. Those few reports of side effects of the vaccine have not been fatal in the majority of times when it comes to the cardiovascular disease element. I'm not talking about allergic reactions. So let's go back and talk about COVID-19 or SARS virus and how does it affect the heart. There are 2 ways. First of all, the receptor for the COVID-19 is on the vessels of the blood vessels. So this COVID actually attaches itself to blood vessels. And so it affects organs like the heart that have a lot of blood vessels. It also affects the kidney and the brain that also have a lot of blood vessels, but those are not for me to talk about. First of all, these receptors that it binds to, then it goes into these endothelial cells and cause damage. And this leads to inflammation of all the vessels in the organ. And we call this state of inflammation myocarditis, and that's what you're hearing about in the news, myocarditis. It is causing microvascular dysfunction because all these small vessels are being injured, and as they become injured, they release what they call cytokines, which are mediators of damage, inflammatory damage. So the body is attempting to kill the cells that are diseased, repair the vessels, and they develop inflammation. And so this inflammation can cause heart failure because the whole organ is inflamed and it might become weak, and that is heart failure. Arrhythmias, because this organ's inflamed and the electrical conduction of the organ may get disturbed. And also there are, most importantly, thromboembolism. Now, blood clots can cause, because the vessel is supposed to be the barrier that keeps the blood from clotting, because when the vessel's intact, there is no reason for the blood to clot. However, when the vessel is torn or injured in some way, then clots could form inside the vessels, and those clots can form anywhere in the body with COVID-19, and they can cause thromboemboli and stroke. So in this slide here, you can see some of the damages I'm talking about, that it can cause heart failure and stroke in the brain from a blood clot that could form in the body, in the heart, or a blood clot that forms in the legs could go to the lungs and cause a pulmonary embolism. And of course, you have arrhythmias and acute coronary syndromes. So these blood clots and damage to the endothelial cells can also damage the arteries that supply the heart, and you can get heart attack. So all these injuries of the heart come with COVID-19, with the SARS-CoV-2 virus. And this is, I'm not talking about the vaccine, I'm talking about the virus. The risk of complications is higher after COVID-19 infection than after COVID-19 vaccination among males and females of all age. So if you're a teenager boy, your risk of complications from the disease is 2 to 6 times that compared to vaccination. And young men, it's 7 to 8 times that compared to vaccination. So what is this slide trying to say? The risk of getting myocarditis from the vaccination was about 1 out of 250,000 people who were vaccinated. About 1 out of 250,000 developed this complication of myocarditis from the vaccine. almost all of them recovered. They were all young men, ages 12 to 17. And we believe they had already had exposed to the virus, and the vaccine merely boosted up the antibodies and caused a temporary exacerbation of the inflammation. When these effects started to wane off, the myocarditis went away, and almost all of them survived. However, in contrast, young men who got the disease, we believed caused myocarditis by MRI studies in as many as 1 out of 19. So you compare the risk of 1 out of 250,000 to 1 out of 19, and you can already begin to see how much more dangerous the disease is than the vaccine. Now, and lastly, the only thing I want to talk about with COVID-19 for you all is why the use of anticoagulation is critical in people afflicted with this disease, because a lot of these COVID-19 complications, the reason why people die, are thromboemboli. I know of a young man, even last month, who was only 23, who unfortunately died after the COVID-19 COVID-19 SARS-CoV-2 infection. In this person, he did not have pneumonia. He had a thrombus that formed in his legs, and it went to his lungs, and unfortunately, it killed them. So cardiovascular complications are contributing about 40% to all COVID-related deaths. So it is critical that if you do have risk of heart disease, that you should ask your doctor to check a marker of inflammation called the D-dimer, and if it's elevated, we suggest that you go on temporarily an anticoagulant until that marker goes away. So I hope that if you have any questions about the vaccine, about COVID on effects on the heart, that you save them for the end of the talk, where I'd be happy to address all of your questions regarding that. The next topic I wanted to touch on briefly is diabetes, because I wanted to emphasize prevention. And it is true that people today who have diabetes are still not aware of the biggest risks to them and what they need to do about it. And so I put it up here for you to see. This slide shows you that if you're a diabetic, your A1C, the amount of hemoglobin that binds to your blood cells, the amount of sugar that binds to your hemoglobin in your red blood cells, should be less than 7%. This measure is a marker of how much you're spilling sugar. And I think most diabetics are aware that they want that to be less than 7%, but it needs to be emphasized here. I also wanted to tell you that when we brought down this number to less than 6%, the diabetics did not do well. And so we do not believe in overregulation of this number. The reason for which we are not clear, perhaps because a lot of these patients in those studies where we were trying to bring down this number to lower levels than 7%, they needed exogenous insulin to do so, and maybe there's something inherently risky about taking exogenous insulin. Be that as it may, the other thing I want to emphasize is blood pressure. B is for blood pressure, less than 120/80. And recently, studies have shown that in elderly patients and in diabetics, the blood pressure should be normal or less. Not 130/80, not 150/90. And I think that many people leave their doctor's offices with blood pressures that are not normal, and more could be done. For every 10 points above 120, your systolic pressure is, you double your risk of heart disease and stroke, and is geometrically increased. So if it's 20 points above normal, it's 6 times the risk of heart attack and stroke. And if it's 30 points above normal, it's 9 times the risk of heart attack and stroke. Blood pressure is a really strong risk factor for getting complications. Controlling your blood pressure is probably the most important thing a doctor can do for you when you go to your visit. Please do not resist him, do not fight him if he wants to increase your medication some more. It is not good to leave your pressure higher. It is a risk, and it should only be acceptable if the risk of the medication outweighs the risk of lowering it. And that's for you and your doctor to decide. Now, The other thing, C, is for cholesterol. Cholesterol, we now no longer is the most risky particle. These LDL particles are what transport cholesterol to all your cells in your body for them to feed on. When you are fed, overfed, which is in the case of many of us, because we're never hungry anymore, we're always in the fed state, we have lots of LDL cholesterol circulating around our blood cells, blood vessels, and this is what deposits in the vessels and causes the plaque. The lowering of this level is critical in cholesterol management. It is much more important than raising your HDL, and it is much more important than lowering your triglycerides, and therefore our goal in diabetics is less than 100, okay? Not less than 130 as it is for normal people. And in people who already have a heart attack or a stroke, we even suggest lowering it to less than 70. And that goal might even be lowering further in the future. If you have any questions about diabetes and disease prevention, certainly save those questions to the end, and I'd be happy to answer them and all of your questions. Of course, I want to talk a little bit about diet, and I think this cartoon illustrates the fact that we need to know what a Mediterranean diet is. And 12 pizzas a day is not really what we mean by Mediterranean diet, as in this cartoon is making fun of. But it's true. A lot of people think that they know what a Mediterranean diet is, and they really don't. And it does behoove you to go online and to find out what it is. In the meantime, I want to say that the Mediterranean diet, the reason why cardiologists like the Mediterranean diet, because it is the only diet that has been studied in randomized controlled clinical trials involving thousands and thousands of patients, that it is superior to a low-fat diet. Compared to a low-fat diet, this was released by Ustech in the New England Journal of Medicine in 2013 in a study of 8,000 patients. He discovered that in this Mediterranean diet, the patients who were on it had 1/3 less risk of dying from heart attack and stroke at the end of 5 years than they did compared to a low-fat diet, which up at that time was the best diet we offered our patients. Now, it's also more interesting that olive oil, the patients in that study who were on olive oil had a 10% lower mortality than even those patients on the Mediterranean diet without olive oil. So we now emphasize the use of olive oil because we think that olive oil might have some properties, anti-cancer properties, as well as properties that are beneficial for cardiovascular disease. So this is the new pyramid to illustrate what a Mediterranean diet really is. And there are also brochures and helpful tips on the internet to help you get started to a true Mediterranean diet. The true Mediterranean diet includes exercise every day. Now, if exercise were a pill, I would give it to everyone. When I wake up in the morning, I go to my exercise bike every morning, and I'm a busy doctor who's getting called from the hospital all the time, and I do 20 minutes on the bicycle. And then I do some light weights, curls, and exercise my upper body strength. If you would do this every day, you will find enormous benefits to your health. The Mediterranean diet includes daily exercise. It's not on this cartoon, but it is part of the Mediterranean diet. Now, most of your calories will be obtained from cereals, beans, legumes, nuts, and seeds. And these we emphasize whole grain breads because the whole grain takes longer for your body to digest. It doesn't release the sugars right away. People ask me, why whole grain? Why not just white bread, white flour, white rice, pizza? What's wrong with those things? Well, the white flour, the white rice, the white pizza, the kernels are degranulated. They're broken up in a flour mill. That's how we get white flour. Therefore, the sugars are exposed. When you ingest white bread, white rice, white flour, pasta, you get sugar in your gut right away, and that causes a peak rise of insulin. You get hungrier. And that's why restaurants serve bread at the table before dinner. It's not because they expect you'll get filled on bread and won't eat anymore. The opposite is true. You tend to eat more food and order more when you eat bread because it makes you hungrier. So I hope the point's well illustrated and you remember it. Of course, daily servings of vegetables and fruit and olive oil are really necessary, daily servings. A few times a week, it's recommended you have fish or seafood, unless you're allergic, of course. And this includes clams and shellfish. Now, as opposed to the older traditional agricultural diet that we used to recommend, we no longer recommend daily dairy, eggs, and poultry, maybe one of these items every day, but we don't recommend them all every day. We don't recommend eggs every day, and we don't recommend milk. I myself have switched to almond milk, a plant-based milk. I use it very, very, very sparingly. And of course, very small amounts of sweet and red meats. Now, of course, it's not forbidden. If a man wants to have a small steak at a restaurant once a month, there's nothing wrong with that. But small amounts are emphasized. Small amounts because we want to reduce saturated fat. I'm sure you're going to have lots of questions about diet. Maybe some, I won't be able to answer all of your questions tonight. But if you have any questions about Mediterranean diet, I want to know them because I want you to be versed in it. This is the data from that New England Journal of Medicine. You can see on the graph over here to your left that the control diet is in black, and this is the mortality, the hazard ratio, which is heart attack, stroke, or death. These are not, weight loss. These are not soft endpoints. These are hard endpoints. They're very hard to manipulate or give you a false positive result. The risk of death, heart attack, or stroke on people on this Mediterranean diet, look at this, was spectacular, was 1/3, the hazard ratio of 0.69, 31% less relatively to the control diet, which was less low fat. Ladies and gentlemen, if this were a pill, I would give it to everyone. Now, look at this graph over here on the right. I hope I can move this out of the way. Okay. You can see the graph on the right. The green line is the Mediterranean diet rich in olive oil, and the brown line is the Mediterranean diet rich in nuts, mixed nuts. And you can see that even compared to the Mediterranean diet without olive oil had a 10% hazard ratio of 0.9, 10% less likelihood of dying over the Mediterranean diet with mixed nuts. Now, it's true that eventually I think the Mediterranean diet with mixed nuts will be superior to the control diet in terms of total mortality if we wait long enough. But the point I'm trying to make is that the extra virgin olive oil had this surprise finding that it started lowering mortality faster than the diet without the olive oil. So this is really fascinating stuff. And it's led to the theory that, like I said, that olive oil may have anti-tumor properties, and that's being studied now as we speak. Okay, now, in terms of diabetes, I wanted to bring to your attention one more very landmark trial that you should all be aware of. Empagliflozin is a new drug, also called Jardiance. There's another one called Farxiga. These new class of drugs inhibit the body's ability to reabsorb sugar in the kidneys. So when you go on these drugs, you start to urinate sugar. Now, it was designed as a new drug to treat diabetes. But when they did the study, they found very, very surprising outcomes. In this study of 48 months, published in the New England Journal of Medicine back in 2015, you can see that the placebo group were the people on metformin, and the empagliflozin group was here in the red. Now, what you can see that in this study, the hazard ratio, there was less likelihood of reaching all these endpoints of cardiovascular disease in the group being treated with this new class of medication. Empagliflozin caused a marked reduction in death from cardiovascular causes. Look at this. In the patients on this drug, compared to metformin, there was a 38% reduced risk of dying from cardiovascular disease. Amazing. And both of these drugs controlled the blood sugar the same. That was controlled for. Look at this, death from any cause. Remarkable, a quite remarkable reduction, the hazard ratio of 0.68. So 34% reduction of death from any cause. This drug, compared to metformin, reduced your risk of dying 34%. And hospitalization from heart failure, it reduced it dramatically. Again, hazard ratio 0.65, 35%. So these drugs have been fast-tracked to be treated for diabetics. If you're a diabetic, you may need this drug. It is also been shown to reduce heart failure even if you're not a diabetic. Why? We're not sure. There's something about urinating sugar that is beneficial. Well, we know when you urinate sugar more, you start to lose weight. Maybe that has something to do with it. Yes, people do tend to lose weight, but we think these effects are far more than that. We don't know the cause. The only side effect from these drugs, the side effects from these drugs, the principal ones, are that if you have to be careful you don't get too dehydrated, because when you urinate sugar, you also lose water with that sugar and you can get dehydrated. So usually we have to, if you're on a water pill, for example, we reduce it. And the other potential problem is urinary tract infections, because your urine is sweet, it's sugary, and therefore yeast might have a tendency to grow more. And so you have to have good hygiene if you use these drugs, and make sure you pay attention to your urinary hygiene and feminine hygiene for women. Now, the next topic I want to talk about is, and I'm almost done, the next topic I want to show is new treatments for cholesterol, not just statins. And there are a couple of new treatments I want to bring to your attention. The first one is Nexatol, or Bedapil. And Bedapil is bempedoic acid is over here. And that really, here's where statins are. And that blocks the production of cholesterol earlier than statins. And it's supposedly, it's by not affecting this, this step over here, it doesn't affect the muscles. So this medicine is still quite expensive because it's not generic yet. But this medicine lowers cholesterol like a statin, but it supposedly is devoid of the muscle aches that you see with the statins. The other drugs are the PCSK9 inhibitors, and there are a couple of new ones. One injection, as shown here, Repatha. This injection blocks it. You take it every 2 weeks. What happens is it goes into your liver and it prevents the production of it prevents the degradation of your LDL receptors. These are the receptors that vacuum up your bad cholesterol. Remember I said your LDL is your bad cholesterol? It vacuums it up on the surface of the liver. Now, just recently, a new injection has come out, inclisiran, which can block the reduction of these LDL receptors for 6 months. All you need is one injection of this, and for 6 months, your cholesterol will be reduced dramatically. Quite an advance, wouldn't you say? So if you have any questions about cholesterol management, please do not hesitate to ask me at the end of this talk, which we're quickly coming to a close. I must mention too briefly about the treatment of angina. If any of you suffer from chronic chest pain or angina, I want to point out to you that here are the treatment strategies for it. And it's not just angioplasty. Coronary blood flow increase can be done with many different medications, not just angioplasty. And we also want to emphasize the treatment of diabetes, regular exercise, rehabilitation, and healthy lifestyle. Many do not realize how exercise and cardiac rehabilitation can really reduce angina. I don't have time to get into all the details, but after trying angioplasty and medication, should you still be having angina, there's a treatment that I do called Eecp, which is this treatment. It's enhanced external counterpulsation. You can see here this lovely woman is getting treated. And basically what this does, so on this machine, all you do is lie down, and this machine pumps blood back to your heart. And when your heart's not pumping, it deflates and it sucks the blood back. So it sort of helps your heart pump, and it bathes your whole body in blood flow, excellent blood flow. And over time, this can reduce the angina in patients 70% of the time. In angina that's not treatable with angioplasty or medications, it reduces it. It's approved by Medicare, and I want to make a plug for it because I do this, and I think it's underutilized often. Unfortunately, patients often have chest pain and they're ignored, and they shouldn't be. And sometimes the doctors don't recognize the chest pain because it takes the form of fatigue or tiredness or shortness of breath, and it's not too readily recognized. So it would be a shame not to avail yourself of this non-invasive treatment should you be one of these patients. Another thing, so now if you have any questions regarding EECP or angina, I'd be happy to answer them at the end of the lecture. Lastly, I want to mention another advance in atrial fibrillation. Just for you people who don't know it, you can now treat the blood clots that form in atrial fibrillation without medications with a new device called the Watchman device. This device is a net or a mesh that goes into the heart. It's inserted invasively, and this closes off this ear in your atrium. You know, when you have atrial fibrillation, your atrium aren't pumping, so the blood's sort of stagnating and flowing in there. And in this clot, 90% of the clots form in this little ear that pinched off when you're in the embryo. And you can see that after a while, after you put it in, after 6 weeks, it becomes completely covered by your body's own tissue. And so after that, you can stop the anticoagulation, and you no longer have to worry about clots forming in this appendage. And you can see on the graph on the right that with this device, you don't have all the bleeding complications you would have because you're not on a blood thinner. You're not on a blood thinner, so you don't have any of the bleeding complication being in a blood thinner. And it's non-inferior to warfarin. It's just the same as being on the older drug, warfarin, or the vitamin K antagonist. It is now being compared to the newer drugs to see how it fares compared to them. And lastly, I want to briefly mention the left ventricular assist devices. Nowadays, people who need heart transplant can have these mechanical hearts put in them, and they are newer methods of pumping the tissues using magnets, and they are becoming much more advanced. And soon they are no longer being used. They're now being used instead of a bridge to transplant as destination therapy for people who have heart failure and need mechanical valves. So I think that brings me to 35 minutes, longer than I had wanted to speak. My apologies. I'm going to now open it up to questions. I'm going to stop sharing the screen. If anybody has any questions, I'm going to try to see if I can find them on the bottom of the screen. No open questions.
So, folks, if you'd like to ask any questions, you can use the Q&A at the bottom of your screen there. If you just move the cursor to the bottom, you'll see a Q&A, or you could type in the chat, and the doctor will be able to see them and answer your questions. Just move your cursor down to the bottom of your screen. You should be able to see that Zoom bar.
So if anybody has any questions, I'm happy to answer them. I hope that the lecture was informative and not too technical. I tried to keep my remarks broad and not dwell too much on the science, but I did want to show you that these recommendations we're making, I wanted to show you the original data because I think it's important for a person to see where we're getting this information from. These studies are pretty convincing if you see the data, as opposed to someone just telling you, oh, we found this, we found that. I think seeing the original data is important, even for laymen. Oh, here's something. Chat screen, okay. Let's see here. Can you please mention the acid drug for LDL? Oh, okay, let me go back. You're talking about, let's see. Oh yeah, Nexatol. Oops. Nexatol is Nexeltol, which is bempedoic acid. It's generic. It's a chemical name, and the trade name is Nexatol. Nexletol. Nexatol. And if you're having a lot of muscle aches from statins, you might want to try that drug. I've had some good experience with it. Let's see, how do I get out of this share screen? Oh yeah, here. Okay. There we go. Okay, good. I don't know how I did that, but I did it. Did I answer your question? I hope that answered your question. Anybody else have any questions? Well, I don't want to, if nobody else has any questions, I want to thank you for having listened to my lecture, and I hope that I've given you I've touched on some important topics that you might enjoy sharing. We discussed COVID-19, how the disease affects the heart, and how not to be, you shouldn't be afraid of the vaccine, and how the vaccine really protects people more against the disease. We discussed a little bit about diet, how to take care of diabetes. We discussed briefly the newer drugs for diabetes that are important for you to be aware of. And we discussed a bit about angina and a bit about atrial fibrillation, about the new ways of not needing drugs for anticoagulation anymore in certain people who would be candidates for that. And lastly, we touched on the artificial heart. So anyway, thank you again for oh wait, one more question here. What's your opinion on the second booster for COVID? I'm glad you answered that. Well, look, I mean, the problem with the vaccine is that it only lasts, the protection of it only lasts about 4 months. So I don't know how useful it is to take a booster if in 4 months you're going to be vulnerable again. So for me, I decided to take the booster. I took the booster once. I'm going to take a second booster before my daughter's wedding this June in Orlando, because I think I'll be exposed to a lot of people. So that's how I decided to do it. If you've already had one booster, I think it's an individual choice. I'm not afraid of getting the booster. I think if you've had a bad reaction to one of the boosters, you might want to not take the second booster. If you've had the disease, you should wait until the antibodies from the disease wane off, which is about, in my opinion, 4 or 5 months. I would follow the CDC recommendations. Another question. Please discuss more implications of shortness of breath. Okay, well, in general, shortness of breath is a very common diagnosis that a cardiologist is faced with. Many people come to me with shortness of breath. My role as a cardiologist is to eliminate 3 major diseases that cause it. Now, of course, a lot of the time, shortness of breath comes from lung disease. That usually can be excluded with a chest X-ray and pulmonary function studies. You have to take a history and see if the person is likely to have lung disease. Are they a smoker, for heaven's sakes? That would be the first thing on my mind. But let's say it's not lung disease. What comes to mind? Well, the 3 diseases that come to my mind, first of all, coronary artery disease. Often the symptom of coronary artery disease will not be chest pain, but it will be shortness of breath, because the tightness in this chest is perceived as shortness of breath. And also, if the heart is being starved of oxygen and not functioning well, the pressures in the lungs could build up and cause the person to perceive shortness of breath. So often that I will perform a stress test on the patient when they come to me with shortness of breath to see for myself what they're talking about, how bad it is, and if there are any related EKG changes or suggestions on, sometimes I do imaging, suggestions on imaging, if the shortness of breath might be caused by the coronary artery disease. Then often I'll do an echocardiogram to look for heart failure. Now, heart failure can be of 2 types. The first type, when the heart muscle is weak, that's easier to identify, and often the echocardiogram is very gratifying, and it tells you right away that why the person has heart failure, and it suggests a treatment strategy. But nowadays, the echocardiogram has become more important because we're learning to look at the relaxation properties of the heart, and we've become much more sophisticated at determining when somebody has shortness of breath from the heart failing to relax. The heart fails to relax often in elderly people. About half the time, heart failure is caused by the heart building up fibrous tissue in it and failing to relax. And this is unfortunately a phenomena of aging, and why it happens more in some people, not others, nobody really understands. But if the heart fills up with fibrous tissue, it can end up getting stiff, and that can end up causing heart failure. And the prognosis from this kind of heart failure is just as bad as that of the weak muscle function. So the echocardiogram and the stress test are the tests we use, and those would be the major causes. Now, if somebody has persistent shortness of breath despite those treatments, that's another question. I would have to start to individualize that. I don't think I could spend all day talking about that here, generalizing, but I hope that answers your question. We have some more questions? No, okay. I guess that's it for the questions. So right now, again, thank you again for listening to me. I appreciate your attendance, and I will hopefully talk to you again sometime soon. Have a nice, happy holidays and a nice weekend.